Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Exagamglogene Autotemcel for severe sickle cell disease. Background. Exagamglogene Autotemcel, XSL, is a non-viral cell therapy designed to reactivate fetal hemoglobin synthesis by means of ex vivo, clustered regularly interspaced short palindromic repeats. CRISPR-Cas9 gene editing of autologous CD34 plus hematopoietic stem and progenitor cells, HSPCs, at the erythroid-specific enhancer region of BCL11A. Methods. We conducted a Phase 3, single-group, label study of XSL in patients 12 to 35 years of age with sickle cell disease who had had at least 2 severe vaso-occlusive crises in each of the 2 years before screening. CD34 plus HSPCs were edited with the use of CRISPR-Cas9. Before the XSL infusion, patients underwent myeloablative conditioning with pharmacokinetically dose-adjusted busulfan. The primary endpoint was freedom from severe vaso-occlusive crises for at least 12 consecutive months. A key secondary endpoint was freedom from inpatient hospitalization for severe vaso-occlusive crises for at least 12 consecutive months. The safety of XSL was also assessed. Results. A total of 44 patients received XSL, and the median follow-up was 19.3 months, range 0.8 to 48.1. Neutrophils and platelets engrafted in each patient. Of the 30 patients who had sufficient follow-up to be evaluated, 29, 97%, 95% confidence interval, CI, 83 to 100, were free from vaso-occlusive crises for at least 12 consecutive months, and all 30, 100%, 95% CI, 88 to 100, were free from hospitalizations for vaso-occlusive crises for at least 12 consecutive months. P less than 0.001 for both comparisons against the null hypothesis of a 50% response. This is. Safety profile of XSL was generally consistent with that of myeloablative busulfan conditioning and autologous HSPC transplantation. No cancers occurred. Conclusions. Treatment with XSL eliminated vaso-occlusive crises in 97% of patients with sickle cell disease for a period of 12 months or more. Exagamglogene Autotemcel for transfusion-dependent beta-thalassemia. Background. Exagamglogene Autotemcel, XSL, is a non-viral cell therapy designed to reactivate fetal hemoglobin synthesis through ex vivo, clustered regularly interspaced short palindromic repeats, CRISPR-Cas9 gene editing of the erythroid-specific enhancer region of BCL11A. In autologous CD34 plus hematopoietic stem and progenitor cells, HSPCs. Methods. We conducted an open-label, single-group, Phase 3 study of XSL in patients 12 to 35 years of age with transfusion-dependent beta-thalassemia and a beta-0/beta-0, beta-0/beta-0-like, or non-beta-0/beta-0-like genotype. CD34 plus HSPCs were edited by means of CRISPR-Cas9 with a guide mRNA. Before the XSL infusion, patients underwent myeloablative conditioning with pharmacokinetically dose-adjusted busulfan. The primary endpoint was transfusion independence, defined as a weighted average hemoglobin level of 9 grams per deciliter or higher, without red cell transfusion for at least 12 consecutive months. Total and fetal hemoglobin concentrations and safety were also assessed. Results. A total of 52 patients with transfusion-dependent beta-thalassemia received XSL and were included in this pre-specified interim analysis. The median follow-up was 20.4 months, range 2.1 to 48.1. Neutrophils and platelets engrafted in each patient. Among the 35 patients with sufficient follow-up data for evaluation, transfusion independence occurred in 32, 91%, 95% confidence interval, 77 to 98, p less than 0.001, against the null hypothesis of a 50% response. During transfusion independence, the mean total hemoglobin level was 13.1 grams per deciliter, and the mean fetal hemoglobin level was 11.9 grams per deciliter, and fetal hemoglobin had a pancellular distribution, greater than or equal to 94% of red cells. This is. Safety profile of exa-cel was generally consistent with that of myeloablative busulfan conditioning and autologous HSPC transplantation. No deaths or cancers occurred. Conclusions. Treatment with exa-cel, preceded by myeloablation, resulted in transfusion independence in 91% of patients with transfusion-dependent β-Thalassemia. Trial of thrombectomy for stroke with a large infarct of unrestricted size. Background. The use of thrombectomy in patients with acute stroke and a large infarct of unrestricted size has not been well studied. Methods. We assigned, in a 1-to-1 ratio, patients with proximal cerebral vessel occlusion in the anterior circulation and a large infarct, as defined by an Alberta Stroke Program early computed tomographic score of less than or equal to 5. Values range from 0 to 10. Detected on magnetic resonance imaging or computed tomography within 6.5 hours after symptom onset to undergo endovascular thrombectomy and receive medical care, thrombectomy group, or to receive medical care alone, control group. The primary outcome was the score on the modified Rankin scale at 90 days. Scores range from 0 to 6, with higher scores indicating greater disability. The primary safety outcome was death from any cause at 90 days, and an ancillary safety outcome was symptomatic intracerebral hemorrhage. Results. A total of 333 patients were assigned to either the thrombectomy group, 166 patients, or the control group, 167 patients. 9 were excluded from the analysis because of consent withdrawal or legal reasons. The trial was stopped early because results of similar trials favored thrombectomy. Approximately 35% of the patients received thrombolysis therapy. The median modified Rankin scale score at 90 days was 4 in the thrombectomy group and 6 in the control group. Generalized odds ratio, 1.63, 95% confidence interval, CI, 1.29 to 2.06, p less than 0.001. Death from any cause, at 90 days, occurred in 36.1% of the patients in the thrombectomy group, and in 55.5% of those in the control group. Adjusted relative risk, 0.65, 95% CI, 0.50 to 0.84, and the percentage of patients with symptomatic intracerebral hemorrhage was 9.6% and 5.7%, respectively. Adjusted relative risk, 1.73, 95% CI, 0.78 to 4.68. 11 procedure-related complications occurred in the thrombectomy group. Conclusions. In patients with acute stroke and a large infarct of unrestricted size, thrombectomy plus medical care resulted in better functional outcomes and lower mortality than medical care alone, but led to a higher incidence of symptomatic intracerebral hemorrhage. Next, we will be discussing articles from Journal of American Medical Association. Ponatinib versus Imatinib, in Frontline Philadelphia Chromosome-Positive Acute Lymphoblastic Leukemia. A randomized clinical trial. Importance, in newly diagnosed Philadelphia Chromosome-Positive, Th+, Acute Lymphoblastic Leukemia, ALL, disease progression, due to acquired resistance to first or second generation BCR, ABL, 1-tyrosine kinase inhibitors is common. Ponatinib inhibits BCR-ABL1 and all single mutation variants, including T315I. Objective: to compare frontline Ponatinib versus Imatinib in adults with newly diagnosed PAESH plus ALL. Design, setting, and participants. Global registrational, Phase 3, open-label trial in adults aged 18 years or older, with newly diagnosed PH plus A.I.O. From January 2019 to May 2022, eligible patients at 77 sites were randomized 2-to-1 to Ponatinib, 30 mg/d, or Imatinib, 600 mg/d, with reduced intensity chemotherapy, followed by single-agent Ponatinib or Imatinib after the cycle 20 phase of the trial. The last date of follow-up for this analysis was August 12, 2022. Intervention patients received Ponatinib, 30 mg/d, or Imatinib, 600 mg/d, with reduced intensity chemotherapy, followed by single-agent Ponatinib or Imatinib after cycle 20. The Ponatinib dose was reduced to 15 mg on achievement of minimal residual disease MRD, negative complete remission. Main outcomes and measures. The primary endpoint of this interim analysis was MRD negative complete remission, less than or equal to 0.01% BCR, ABL1, MR4, centrally assessed by reverse transcriptase quantitative polymerase chain reaction, with complete remission maintained for at least 4 weeks at the end of cycle 3. The key secondary endpoint was event-free survival. Results of 245 patients randomized, median age, 54 years, 133, 54.3%, female, 232, Ponatinib, N equals 154, Imatinib, N equals 78, who had P190 or P210 dominant isoforms verified by the central laboratory, were analyzed for the primary endpoint. The MRD negative complete remission rate, primary endpoint, was significantly higher with Ponatinib, 34.4%, 53,154, versus Imatinib, 16.7%, 1378, risk difference, 0.18, 95% CI, 0.06 to 0.29, P equals 0.002. At the data cutoff, event-free survival had not met the prespecified number of events. Median event-free survival was not reached in the Ponatinib group and was 29 months in the Imatinib group. The most common adverse events were similar between treatment groups. Arterial occlusive events were infrequent and comparable between groups. Ponatinib, 2.5%, Imatinib, 1.2%. Conclusions and relevance. Ponatinib demonstrated a superior rate of MRD negative complete remission at the end of induction versus Imatinib when combined with reduced intensity chemotherapy in adults with newly diagnosed PH plus A.I.O. The safety profile of Ponatinib was comparable with Imatinib. Associations of Internal Medicine Residency, Milestone Ratings and Certification Examination Scores, with Patient Outcomes. Importance. Despite its importance to medical education and competency assessment for internal medicine trainees, evidence about the relationship between physicians' Milestone Residency Ratings, or the American Board of Internal Medicine's initial certification examination, and their hospitalized patients' outcomes, is sparse. Objective. To examine the association between physicians' milestone ratings and certification examination scores and hospital outcomes for their patients. Design, setting, and participants. Retrospective cohort analyses of 6,898 hospitalists completing training in 2016 to 2018 and caring for Medicare fee-for-service beneficiaries during hospitalizations in 2017 to 2019 at U.S. hospitals. Exposure certification examination score quartile and milestone ratings, including an overall core competency rating measure equaling the mean of the end of residency milestone subcompetency ratings, categorized as low, medium, or high, and a knowledge core competency measure categorized similarly. Results among 455 120 hospitalizations, median patient age was 79 years, IQR, 73 to 86 years. 56.5% of patients were female, 1.9% were Asian, 9.8% were Black, 4.6% were Hispanic, and 81.9% were white. The 7-day mortality and readmission rates were 3.5%, 95% CI, 3.4% to 3.6%, and 5.6%, 95% CI, 5.5% to 5.6%, respectively, and were 8.8%, 95% CI, 8.7% to 8.9%, and 16.6%, 95% CI, 16.5% to 16.7% for mortality and readmission at 30 days. Mean length of stay and number of specialty consultations were 3.6 days, 95% CI, 3.6 to 3.6 days, and 1.01, 95% CI, 1.00 to 1.03, respectively. A high versus low overall or knowledge milestone core competency rating was associated with none of the outcome measures assessed. For example, a high versus low overall core competency rating was associated with a non-significant 2.7% increase in 7-day mortality rates, 95% CI, minus 5.2% to 10.6%. P equals 0.51. In contrast, top versus bottom examination score quartile was associated with a significant 8.0% reduction in 7-day mortality rates, 95% CI, minus 13.0% to minus 3.1%. P equals 0.002, and a 9.3% reduction in 7-day readmission rates, 95% CI, minus 13.0% to minus 5.7%, P less than 0.001. For 30-day mortality, this association was minus 3.5%, 95% CI, minus 6.7% to minus 0.4%, P equals 0.03. Top versus bottom examination score quartile was associated with 2.4% more consultations, 95% CI, 0.8% to 3.9%, P less than 0.003, but was not associated with length of stay or 30-day readmission rates. Conclusions and relevance among newly trained hospitalists, certification examination score, but not residency milestone ratings, was associated with improved outcomes among hospitalized Medicare beneficiaries. Next, we will be discussing articles from Annals of Internal Medicine. The Safety of Outpatient Healthcare, Review of Electronic Health Records. Background. Despite considerable emphasis on delivering safe care, substantial patient harm occurs. Although most care occurs in the outpatient setting, knowledge of outpatient adverse events, AEs, remains limited. Objective. To measure AEs in the outpatient setting. Design. Retrospective review of the electronic health record, EHR, setting. 11 outpatient sites in Massachusetts in 2018. Patients. 3,103 patients who received outpatient care. Measurements. Using a trigger method, nurse reviewers identified possible AEs and physicians adjudicated them, ranked severity, and assessed preventability. Generalized estimating equations were used to assess the association of having at least one AE with age, sex, race, and primary insurance. Variation in AE rates was analyzed across sites. Results. The 3,103 patients, mean age, 52 years, were more often female, 59.8%, white, 75.1%, English speakers, 90.8%, and privately insured, 70.4%, and had a mean of 4 outpatient encounters in 2018. Overall, 7.0%, 95% CI, 4.6% to 9.3% of patients had at least one AE, 8.6 events per 100 patients annually. Adverse drug events were the most common AE, 63.8%, followed by healthcare-associated infections, 14.8%, and surgical or procedural events, 14.2%. Severity was serious in 17.4% of AEs, life-threatening in 2.1%, and never fatal. Overall, 23.2% of AEs were preventable. Having at least one AE was less often associated with ages 18 to 44 years than with ages 65 to 84 years. Standardized risk difference, minus 0.05, CI, minus 0.09 to minus 0.02, and more often associated with Black race than with Asian race. Standardized risk difference, 0.09, CI, 0.01 to 0.17. Across study sites, 1.8% to 23.6% of patients had at least one AE, and clinical category of AEs varied substantially. Limitation. Retrospective EHR review may miss AEs. Conclusion. Outpatient harm was relatively common and often serious. Adverse drug events were most frequent. Rates were higher among older adults. Interventions to curtail outpatient harm are urgently needed. Diagnostic strategy using colors. Doppler ultrasound of temporal arteries in patients with high clinical suspicion of giant cell arteritis, a prospective cohort study. Background. Giant cell arteritis, GCA, is the most prevalent systemic vasculitis in people older than 50 years. Any delay in diagnosis impairs patients' quality of life and can lead to permanent damage, particularly vision loss. Objective. To evaluate a diagnostic strategy for GCA using colored Doppler ultrasound of the temporal artery as a first-line diagnostic test, temporal artery biopsy, TAB, as a secondary test, and physician expertise as the reference method. Design. Prospective multicenter study with a 2-year follow-up. ClinicalTrials.gov, NCT 027-03-922 setting. Patients were referred by their general practitioner or ophthalmologist to a physician with extensive experience in GCA diagnosis and management in one of the participating centers, 4 general and 2 university hospitals. Patients. 165 patients with high clinical suspicion of GCA, aged 79 years, IQR, 73 to 85 years. Intervention. The diagnostic procedure was ultrasound, performed less than 7 days after initiation of corticosteroid therapy. Only ultrasound-negative patients underwent TAB. Measurements. Bilateral temporal halo signs seen on ultrasound were considered positive. Ultrasound and TAB results were compared with physician-diagnosed GCA based on clinical findings and other imaging. Results. Diagnosis of GCA was confirmed in 44%, 17%, and 21% of patients by ultrasound, TAB, and clinical expertise and/or other imaging tests, respectively. Their diagnosis remained unchanged at 1 month and 2 years for those with available follow-up data. An alternative diagnosis was made in 18% of patients. The proportion of ultrasound-positive patients among patients with a clinical GCA diagnosis was 54%, 95% CI, 45% to 62%. Limitation. Small sample size, no blinding of ultrasound and TAB results, lack of an objective Goldstandard comparator, and single diagnostic strategy. Conclusion. By using ultrasound of the temporal arteries as a first-line diagnostic tool in patients with high clinical suspicion of GCA, further diagnostic tests for patients with positive ultrasound were avoided. Next, we will be discussing articles from Nature Medicine. Single-cell transcriptomic analyses reveal distinct immune cell contributions to epithelial barrier dysfunction in checkpoint inhibitor colitis. Immune checkpoint inhibitor, ICI, therapy has revolutionized oncology, but treatments are limited by immune-related adverse events, including checkpoint inhibitor colitis, ear colitis. Little is understood about the pathogenic mechanisms driving ear colitis, which does not readily occur in model organisms, such as mice. To define molecular drivers of ear colitis, we used single-cell multiomics to profile approximately 300,000 cells from the colon mucosa and blood of 13 patients with cancer who developed ear colitis. 9 on anti-PD-1 or anti-CTLA-4 monotherapy, and 4 on dual ICI therapy. Most patients had skin or lung cancer, 8 controls on ICI therapy, and 8 healthy controls. Patients with ear colitis showed expanded mucosal tregs, IgE CD8, tissue-resident memory T cells, expressing CXCL13 and Th17 gene programs, and recirculating IgB2 high, CD8 T cells, cytotoxic NALI, CD4 T cells, recirculating EGB2 high CD8 T cells, and endothelial cells, expressing hypoxia gene programs were further expanded in colitis, associated with anti-PD-1/CTLA-4 therapy, compared to anti-PD-1 therapy. Luminal epithelial cells in patients with ear colitis expressed PCSK9, PDL1, and interferon, induced signatures associated with apoptosis, increased cell turnover, and malabsorption. Together, these data suggest roles for circulating T cells and epithelial immune crosstalk, critical to PD-1/CTLA-4 dependent tolerance and barrier function, and identify potential therapeutic targets for ear colitis. Next, we will be discussing articles from Lancet. Preventive percutaneous coronary intervention versus optimal medical therapy alone for the treatment of vulnerable atherosclerotic coronary plaques. Prevent. A multicenter, open-label, randomized controlled trial. Background. Acute coronary syndrome and sudden cardiac death are often caused by rupture and thrombosis of lipid-rich atherosclerotic coronary plaques, known as vulnerable plaques, many of which are non-flow limiting. The safety and effectiveness of focal preventive therapy with percutaneous coronary intervention of vulnerable plaques and reducing adverse cardiac events are unknown. We aimed to assess whether preventive percutaneous coronary intervention of non-flow limiting vulnerable plaques improves clinical outcomes compared with optimal medical therapy alone. Findings. Between Sept 23, 2015, and Sept 29, 2021, 5,627 patients were screened for eligibility, 1,606 of whom were enrolled and randomly assigned to percutaneous coronary intervention, N equals 803, or optimal medical therapy alone, N equals 803. 1,177, 73%, patients were men, and 429, 27%, were women. 2-year follow-up for the primary outcome assessment was completed in 1556. 97%. Patients, percutaneous coronary intervention group, N equals 780. Optimal medical therapy group, N equals 776. At 2 years, the primary outcome occurred in 3.4% patients in the percutaneous coronary intervention group, and in 3.4% patients in the medical therapy group. Absolute difference, 3.0 percentage points, 95% CI4.4 to 1.8. P equals 0.0003. The effect of preventive percutaneous coronary intervention was directionally consistent for each component of the primary composite outcome. Serious clinical or adverse events did not differ between the percutaneous coronary intervention group and the medical therapy group at 2 years. 0.5% versus 1.3%, patients died. Absolute difference, 0.8 percentage points, 95% CI 1.7 to 0.2, and 1.1% versus 1.7%. Patients had myocardial infarction. Absolute difference 0.5 percentage points, 1.7 to 0.6. Interpretation. In patients with non-flow limiting vulnerable coronary plaques, preventive percutaneous coronary intervention reduced major adverse cardiac events arising from high-risk vulnerable plaques compared with optimal medical therapy alone. Given that PREVENT is the first large trial to show the potential effect of the focal treatment for vulnerable plaques, these findings support consideration to expand indications for percutaneous coronary intervention to include non-flow limiting, high-risk vulnerable plaque. Next, we will be discussing articles from Journal of Clinical Oncology. Phase 2 trial of nab-sirolimus in patients with advanced malignant perivascular epithelioid cell tumors. Impact, long-term efficacy and safety update. Nab-sirolimus is approved in the United States for the treatment of metastatic or locally advanced malignant perivascular epithelioid cell tumor, PE-coma, on the basis of the primary analysis results of the Phase 2 advanced malignant perivascular epithelioid cell tumors. Impact, trial, clinicaltrials.gov identifier, NCT 02494570. Results from the primary analysis were previously published. However, the median duration of response, MDR, had not been reached at that time. Here, 3 years after the primary analysis, we report final efficacy and safety data. Data cutoff, April 29, 2022. At study completion, the confirmed overall response rate, by independent radiologist review using RECIST v1.1, was 38.7%, 95% CI, 21.8 to 57.8, with an additional converted confirmed complete response, N equals 2. Median progression-free survival remained the same at 10.6 months, 95% CI, 5.5 to 41.2. The MDR was reached at 39.7 months, 95% CI, 6.5 to not reached, NR, and the median overall survival at completion was 53.1 months, 95% CI, 22.2 to NR. The most common treatment-related adverse events, TRAEs, were stomatitis, 82.4%, and fatigue and rash, each 61.8%. No new or unexpected adverse events occurred, and no grade greater than or equal to 4 TRAEs were reported. These results highlight the long-term clinical benefit of nab-sirolimus in patients with advanced malignant PE coma, with a DO of greater than 3 years. Next, we will be discussing articles from Journal of Hepatology. Clinical profiles and mortality rates are similar for metabolic dysfunction-associated steatotic liver disease and non-alcoholic fatty liver disease. Background and aims. Recently, the term metabolic dysfunction-associated steatotic liver disease, MASLD, has replaced non-alcoholic fatty liver disease, NAFLD. Concern remains regarding whether the evidence generated under the NAFLD definition can be used for MASLD. We compared the clinical profile and outcomes of NAFLD to MASLD using tertiary care and population-based data methods. Comparison data were obtained from our NAFLD database and the National Health and Nutrition Examination Survey, NHANES 3. Clinical profiles and non-invasive tests, enhanced liver fibrosis, ELF, score, Fibrosis 4 Index, FIB4, and vibration-controlled transient elastography were compared. Mortality data were obtained from NHANES National Death Index. All-cause mortality was assessed by Cox proportional hazards regression models and cause-specific mortality by competing risk analysis. Results. There were 6,429 patients in the NAFLD database. Age, 54 plus or minus 12 years. 42% male. BMI 35.4, plus or minus 8.3, waist circumference 112, plus or minus 17 centimeters, 52% type 2 diabetes. Average scores for ELF, FIB4, and liver stiffness were 9.6 plus or minus 1.2, 1.69, plus or minus 1.24, 14.0, plus or minus 11.8 kilopascals, respectively. 99% met MASLD criteria, 95% met MASLD on BMI only. Predictive accuracy of ELF and FIB4 were identical between MASLD and NAFLD. We included 12,519 eligible participants from NHANES, age 43.00 years, 47.38% male, 22.70% obese, 7.28% type 2 diabetes, 82.51% greater than or equal to 1 cardiometabolic criteria. Among the NHANES study population, there was excellent concordance between MASLD and NAFLD diagnoses. Cohen's kappa coefficient, 0.968, 95% CI 0.962 to 0.973, with 5.29% of NAFLD cases not meeting MASLD criteria. After a median follow-up of 22.83 years, there were no mortality differences between MASLD and NAFLD diagnoses. P-values greater than or equal to 0.05. Conclusions. NAFLD and MASLD are similar, except individuals with MASLD seem to be older with slightly higher mortality risk, likely owing to cardiometabolic risk factors. Clinical profiles and non-invasive test thresholds were also identical. These data provide evidence that NAFLD and MASLD terminologies can be used interchangeably. For the small proportion of patients with NAFLD who do not meet MOSLD criteria, further consideration is needed. Molecular force-induced liberation of transforming growth factor beta remodels the spleen for ectopic liver regeneration. Background and aims. Ectopic liver regeneration in the spleen is a promising alternative to organ transplantation for treating liver failure. To accommodate transplanted liver cells, the splenic tissue must undergo structural changes to increase extracellular matrix content, demanding a safe and efficient approach for tissue remodeling. Methods. We synthesized sulfated hyaluronic acid, SHA, with an affinity for the latent complex of transforming growth factor beta, TGF-beta, and cross-linked it into a gel network, SHA-X, via click chemistry. We injected this glycan into the spleens of mice to induce splenic tissue remodeling via supraphysiological activation of endogenous TGF-beta. Results. SHA-X efficiently bound to the abundant latent TGF-beta in the spleen. It provided the molecular force to liberate the active TGF-beta dimers from their latent complex, mimicking the bind and pull mechanism required for physiological activation of TGF-beta, and reshaping the splenic tissue to support liver cell growth. Hepatocytes transplanted into the remodeled spleen developed into liver tissue with sufficient volume to rescue animals with a metabolic liver disorder, FA/transgenic model, or following 90% hepatectomy, with no adverse effects observed and no additional drugs required. Conclusion. Our findings highlight the efficacy and translational potential of using SHA-X to remodel a specific organ by mechanically activating one single cytokine, representing a novel strategy for the design of biomaterials-based therapies for organ regeneration. Impact and implications. Cell transplantation may provide a lifeline to millions of patients with end-stage liver diseases, but their severely damaged livers being unable to accommodate the transplanted cells is a crucial hurdle. Herein, we report an approach to restore liver functions in another organ, the spleen, by activating one single growth factor in situ. This approach, based on a chemically designed polysaccharide that can mechanically liberate the active transforming growth factor beta to an unusually high level, promotes the function of abundant allogenic liver cells in the spleen, rescuing animals from lethal models of liver diseases, and showing a high potential for clinical translation. Next, we will be discussing articles from Clinical Gastroenterology. Type 1 Autoimmune Pancreatitis in Europe, Clinical Profile and Response to Treatment. Background and aims. Autoimmune pancreatitis, AIP, is an immune-mediated disease of the pancreas, with distinct pathophysiology and manifestations. Our aims were to characterize type 1 AIP in a large pan-European cohort, and study the effectiveness of current treatment regimens. Methods. We retrospectively analyzed adults diagnosed since 2005, with type 1 or not otherwise specified AIP, in 42 European university hospitals. Type 1 AIP was uniformly diagnosed, using specific diagnostic criteria. Patients with type 2 AIP, and those who had undergone pancreatic surgery, were excluded. The primary endpoint was complete remission, defined as the absence of clinical symptoms and resolution of the index radiologic pancreatic abnormalities, attributed to AIP. Results. We included 735 individuals with AIP, 69% male, median age, 57 years, 85% white. Steroid treatment was started in 634 patients, of whom 1% were lost to follow-up. The remaining 625 had a 79%, 496 625, complete, 18%, 111 625, partial, and 97%, 607 625, cumulative remission rate, whereas 3%, 18 625, did not achieve remission. No treatment was given in 95 patients, who had a 61% complete, 58.95, 19% partial, 18.95, and 80% cumulative, 76.95, spontaneous remission rate. Higher, greater than or equal to 0. 4 mg/kg/day, corticosteroid doses were no more effective than lower. less than 0.4 mg/kg/day, doses, odds ratio, 0.428, 95% confidence interval, 0.054 to 3.387, and neither was a starting dose duration greater than 2 weeks, odds ratio, 0.908, 95% confidence interval, 0.818 to 1.009. Elevated Ig-4 levels were independently associated with a decreased chance of complete remission, odds ratio, 0.639, 95% confidence interval, 0.427 to 0.955. Relapse occurred in 30% of patients. Relapses within 6 months of remission induction were independent of the steroid tapering duration, induction treatment duration, and total cumulative dose. Conclusions. Patients with type 1 APE and elevated Ig-4 level may need closer monitoring. For remission induction, a starting dose of 0.4 mg/kg/day for 2 weeks, followed by a short taper period, seems effective. This study provides no evidence to support more aggressive regimens. Screening for fibrosis promotes lifestyle changes. A prospective cohort study in 4,796 individuals. Background and aims. Early detection of liver fibrosis is believed to promote lifestyle changes. We evaluated self-reported changes in alcohol intake, diet, exercise, and weight after participating in a screening study for liver fibrosis. Methods. We conducted a prospective screening study of individuals at risk of alcohol-related liver disease, ALD, or metabolic dysfunction-associated steatotic liver disease, MOSLD. We provided lifestyle advice to all participants and evaluated lifestyle changes by questionnaires after 1 week and 6 months, with re-examination of a subgroup after 2 years. Results. A total of 1,850 at risk of ALD and 2,946 at risk of MOSLD were included, of whom 383, 8%, were screening positive, transient elastography, greater than or equal to 8 kPa. A total of 84% replied to the 6-month questionnaire. In ALD participants, excessive drinking decreased from 46% to 32% after 6 months. Only 15% reported increased drinking, without differences between screening positive and negative individuals, p equals 0.698. In high-risk drinkers, a positive screening test predicted abstinence or decreased alcohol use after 6 months. Odds ratio, 2.45. 95% confidence interval, 1.32 to 4.57. P equals 0.005. After 2 years, excessive drinking decreased from 52% to 41% in a subgroup of 752 individuals and a positive screening test predicted abstinence or decreased alcohol use after 2 years. Odds ratio, 1.84. 95% confidence interval, 1.09 to 3.11. P equals 0.023. MOSLD participants showed similar improvements. 35% improved their diet, 22% exercised more, and 13% reported a weight loss greater than or equal to 5% after 6 months. Conclusions. Screening for liver fibrosis is associated with sustained improvements in alcohol consumption, diet, weight, and exercise in at-risk ALD and MOSLD. The changes are most pronounced in screening positive participants, but not limited to this group. Interpret, a randomized controlled trial of vedolizumab dose optimization in patients with ulcerative colitis who have early non-response. Background and aims. Patients with ulcerative colitis, UC, may experience non-response to biologics, possibly as a result of low drug exposure. This trial assessed the efficacy of dose optimization in patients with UC who have early non-response to vedolizumab and high drug clearance. Methods. Interpret was a Phase 4, open-label, randomized, controlled trial that included patients with moderate to severe UC who had high drug clearance at week 5, serum concentration less than 50 g per milliliter, and non-response to standard vedolizumab treatment at week 6. At week 6, eligible patients were randomized 1:1 to receive standard dosing, 300 mg every 8 weeks, or dose-optimized vedolizumab, 600 mg at week 6, then 300 mg every 4 weeks, or 600 mg at week 6, then 600 mg every 4 weeks, based on week 5 serum concentration. The primary endpoint was endoscopic improvement at week 30. Results: of 278 enrolled patients, 132, 47.5%, had a clinical response at week 6. From week 6, 108 patients received standard, N equals 53, or dose-optimized vedolizumab, N equals 55. Among patients with non-response at week 6, 86.5% had high drug clearance. At week 30, 10 patients, 18.9%, who received standard vedolizumab had endoscopic improvement versus 8 patients, 14.5%, who received dose-optimized vedolizumab. 5 patients, 9.4%, who received standard vedolizumab had clinical remission at week 30 versus 5 patients, 9.1%, who received dose-optimized vedolizumab. Clinical response was observed in 17, 32.1%, and 17 patients, 30.9%, respectively. Safety event rates were similar among treatment groups. Conclusions: in patients with early non-response and high drug clearance, vedolizumab dose optimization is probably not required. A proportion of patients benefited from continued treatment, irrespective of the dose received. Next, we will be discussing articles from Clinical Infectious Diseases. Impact of a purified microbiome. Therapeutic on abundance of antimicrobial resistance genes in patients with recurrent Clostridioides difficile infection. Background: the gastrointestinal microbiota is an important line of defense against colonization with antimicrobial resistant AR bacteria. In this post-hoc analysis of the Phase 3 EcoSpur 3 trial, we assessed impact of a microbiota-based oral therapeutic, fecal microbiota spores, live, VOUST oral spores, VOS, formerly SIR 109, series therapeutics, compared with placebo, on ARG, abundance in patients with recurrent Clostridioides difficile infection, methods. Adults with ARCD were randomized to receive VOS or placebo orally for 3 days following standard of care antibiotics. ARG and taxonomic profiles were generated using whole metagenomic sequencing of stool at baseline and weeks 1, 2, 8, and 24 post-treatment. Results: baseline, N equals 151, and serial post-treatment stool samples collected through 24 weeks. Total N equals 472. From 182 patients, 59.9% female, mean age, 65.5 years. In EcoSpur 3, as well as 68 stool samples obtained at a single time point from a healthy cohort were analyzed. Baseline ARG abundance was similar between arms and significantly elevated versus the healthy cohort. By week 1, there was a greater decline in ARG abundance in VOS versus placebo, p equals 0.003, in association with marked decline of proteobacteria and repletion of spore-forming Firmicutes, as compared with baseline. We observed abundance of proteobacteria and non-spore-forming Firmicutes were associated with ARG abundance, while spore-forming Firmicutes abundance was negatively associated. Conclusions: this proof-of-concept analysis suggests that microbiome remodeling with Firmicutes spores may be a potential novel approach to reduce ARG colonization in the gastrointestinal tract. A systematic review of predictor composition, outcomes, risk of bias, and validation of COVID-19 prognostic scores. Background: numerous prognostic scores have been published to support risk stratification for patients with coronavirus disease, 2019, COVID-19. Methods: we performed a systematic review to identify the scores for confirmed or clinically assumed COVID-19 cases. An in-depth assessment and risk of bias ROB analysis, prediction model risk of bias assessment tool, PROBASED, was conducted for scores fulfilling predefined criteria, area under the curve, AUC, greater than or equal to 0.75. 2. A separate validation cohort present. 3. Training data from a multi-center setting, greater than or equal to 2 centers. 4. Point scale scoring system. Results. Out of 1,522 studies extracted from Medline/Web of Science, February 20, 2023, we identified 242 scores for COVID-19 outcome prognosis, mortality 109, severity 116, hospitalization 14, long-term sequelae 3. Most scores were developed using retrospective, 75.2%, or single-center, 57.1%, cohorts. Predictor analysis revealed the primary use of laboratory data and socio-demographic information in mortality and severity scores. 49 scores were included in the in-depth analysis. The results indicated heterogeneous quality and predictor selection, with only 5 scores featuring low ROB. Among those, based on the number and heterogeneity of validation studies, only the 4C mortality score can be recommended for clinical application so far. Conclusions. The application and translation of most existing COVID scores appear unreliable. Guided development and predictor selection would have improved the generalizability of the scores and may enhance pandemic preparedness in the future. Compared performance of the 2023 Duke International Society for Cardiovascular Infectious Diseases, 2000 Modified Duke, and 2015 European Society of Cardiology criteria for the diagnosis of infective endocarditis in a French multicenter prospective cohort. Background. The 2023 Duke International Society for Cardiovascular Diseases (ISCVD) criteria for infective endocarditis (IE) were proposed as an updated diagnostic classification of IE. Using an open prospective multicenter cohort of patients treated for IE, we compared the performance of these new criteria to that of the 2000 Modified Duke and 2015 European Society of Cardiology (ESCAPE) criteria. Methods. Cases of patients treated for IE between January 2017 and October 2022 were adjudicated as certain IE or not. Each case was also categorized as either definite or possible/rejected within each classification. Sensitivity, specificity, and accuracy were estimated with 95% confidence intervals. Results. Of the 1,194 patients analyzed, mean age, 66.1 years, 71.2% males, 414, 34.7%, had a prosthetic valve and 284, 23.8%, had a cardiac implanted electronic device, CIED, 946, 79.2% were adjudicated as certain IE, 978, 81.9%, 997, 83.5%, and 1,057, 88.5%, were classified as definite IE in the 2000 Modified Duke, 2015 ESCAPE, and 2023 Duke ISCVD criteria, respectively. The sensitivity of each set of criteria was 93.2%, 95% confidence interval, CI, 91.6 to 94.8, 95.0%, 95% CI, 93.7 to 96.4, and 97.6%, 95% CI, 96.6 to 98.6, respectively, p less than 0.001 for all 2x2 comparisons. Corresponding specificity rates were 61.3%, 95% CI, 55.2 to 67.4, 60.5%, 95% CI, 54.4 to 66.6, and 46.0%, 95% CI, 39.8 to 52.2, respectively. In patients without seed, sensitivity rates were 94.8%, 95% CI, 93.2 to 96.4, 96.5%, 95% CI, 95.1 to 97.8, and 97.7%, 95% CI, 96.6 to 98.8. Specificity rates were 59.0%, 95% CI, 51.6 to 66.3, 56.6%. 95% CI, 49.3 to 64.0, and 53.8%, 95% CI, 46.3 to 61.2, respectively. Conclusions. Overall, the 2023 Duke-ISCVID criteria had a significantly higher sensitivity, but a significantly lower specificity, compared with older criteria. This decreased specificity was mainly attributable to patients with SED. Next, we will be discussing articles from Journal of Clinical Rheumatology. Measurement of EITH. Neutrophil extracellular traps as a biomarker for the differential diagnosis between anti-neutrophil cytoplasmic antibody-positive individuals with anti-neutrophil cytoplasmic antibody-associated vasculitis and non-autoimmune diseases. Background/objective. Neutrophil extracellular traps, NETs, have a correlation with disease activity in anti-neutrophil cytoplasmic antibody, ANCA-associated vasculitis, AAV. However, it is not known whether there is an association between NETs and the presence of ANCA in other diseases. This study aimed to assess the occurrence of NETs in individuals with ANCA, and whether serum NET quantitation is capable of distinguishing them with regard to the diagnosis. Methods. This was a cross-sectional, observational study. From the positive ANCA, by indirect immunofluorescence, 94 individuals were divided into groups: A.I.O, infectious diseases, and neoplastic diseases. Healthy controls served for comparisons. Neutrophil extracellular traps were evaluated through the investigation of NET remnants. By detecting cell-free DNA bound to proteins such as histone, myeloperoxidase, and neutrophil elastase, NE. Results. In patients with paranuclear ANCA, P-ANCA, the detection of NETs by NE was able to distinguish AV from infection/neoplasia and healthy controls. Receiver operating characteristic curves for serum NETs by NE in patients with P-ANCA were drawn in two situations: AV versus infection/neoplasia, showing a sensitivity of 0.65 and specificity of 0.84, with an area under the curve of 65%, and AV versus controls, showing a sensitivity of 0.84 and a specificity of 0.88, with an area under the curve of 96%. Conclusions. For P-ANCA positive individuals, we found higher serum NETs detected by NE DNA in those with chronic infectious and neoplastic diseases than in AV individuals and healthy controls. This allows us to infer that the evaluation of serum NETs may be of value as a biomarker for differential diagnosis. Prediction of treatment. Effect of SLE-ITP patients based on cost-sensitive neural network and variational autoencoder. Objective. The aim of the study was to examine the factors influencing the therapeutic effect of patients with systemic lupus erythematosus combined with immune thrombocytopenia, SLE-ITP, and develop a prediction model to predict the therapeutic effect of SLE-ITP. Methods. 324 SLE-ITP patients were retrieved from the electronic health record database of SLE patients in Jiangsu Province, according to the latest treatment response criteria for ITP. We adopted the Cox model, based on the least absolute shrinkage and selection operator, to explore the impact factors affecting patient therapeutic effect, and we developed neural network model to predict therapeutic effect. And in prediction model, cost sensitivity was introduced to address data category imbalance, and variational autoencoder was used to achieve data augmentation. The performance of each model was evaluated by accuracy and the area under the receiver operator curve. Results. The results showed that B lymphocyte count, H cholesterol level, complement 3 level, anti-cardiolipin antibody, and so on could be used as predictors of SLE-ITP curative effect, and abnormal levels of alanine transaminase, immunoglobulin A, and apolipoprotein B predicted adverse treatment response. The neural network treatment effect prediction model, based on cost sensitivity and variational autoencoder, was better than the traditional classifiers. with an overall accuracy rate close to 0.9 and a specificity of more than 0.9, which was useful for clinical practice to identify patients at risk of ineffective treatment response and to achieve better individualized management. Conclusions. By predicting the curative effect of SLE-ITP, the severity of patients can be determined, and then the best treatment strategy can be planned to avoid ineffective treatment. Next, we will be discussing articles from Arthritis and Rheumatology. Anti-inflammatory. Effect of high-density lipoprotein blunted by delivery of altered microRNA cargo in patients with rheumatoid arthritis. Objective. High-density lipoprotein, HDL, has well-characterized anti-atherogenic cholesterol efflux and antioxidant functions. Another function of HDL, uncharacterized in rheumatoid arthritis, RA, is its ability to transport microRNAs, miRNAs, between cells, and thus alter cellular function. The study's purpose was to determine if HDL miRNA cargo is altered and affects inflammation in RA. Methods. HDL microRNAs were characterized in 30 RA and 30 control participants by next-generation sequencing and quantitative polymerase chain reaction. The most abundant differentially expressed miRNA was evaluated further. The function of miR-1246 was assessed by miRNA mimics, antagamy-Rs, small interfering RNA knockdown, and luciferase assays. Monocyte-derived macrophages were treated with miR-1246 loaded HDL and unmodified HDL from RA and control participants to measure delivery of miR-1246 and its effect on interleukin-6, IL-6. Results. The most abundance miRNA on HDL was miR-1246. It was significantly enriched twofold on HDL from RA versus control participants. HDL-mediated miR-1246 delivery to macrophages significantly increased IL-6 expression 43-fold. miR-1246 delivery significantly decreased DUSP3 1.5-fold, and DUSP3 small interfering RNA knockdown increased macrophage IL-6 expression. Luciferase assay indicated DUSP3 is a direct target of miR-1246. Unmodified HDL from RA delivered 1.6-fold more miR-1246 versus control participant HDL. Unmodified HDL from both RA and control participants attenuated activated macrophage IL-6 expression, but this effect was significantly blunted in RA, so that IL-6 expression was 3.4-fold higher after RA versus control HDL treatment. Conclusion. HDL miR-1246 was increased in RA versus control participants, and delivery of miR-1246 to macrophages increased IL-6 expression by targeting DUSP3. The altered HDL miRNA cargo in RA blunted HDL's anti-inflammatory effect. Next, we will be discussing articles. American College of Cardiology. LGE-CMR, and sudden death in hypertrophic cardiomyopathy. Study questions. What is the prognostic value of extent of late gadolinium enhancement, LGE, in predicting sudden cardiac death, SCD, in patients with hypertrophic cardiomyopathy, HCM? Methods. This study is a meta-analysis of all studies of HCM patients with cardiac magnetic resonance imaging, CMR, who had quantitative LGE reported as a fraction of the left ventricular, LV, mass. The primary outcome of interest was SCD. Additional subgroup comparisons were made by method of LGE assessment, risk for SCD, and existence of LV outflow tract obstruction. Results. Overall, 11 studies were included with 1,550 patients, with a mean age of 51 years, and 64% were male. The median follow-up period was 5.2 years. Heterogeneity across studies was low. SCD highly correlated with LGE, with a pooled odds ratio of 4.93, 95% confidence interval, 3.75 to 6.47. There was no statistical difference in association between LGE and SCD by method of ascertaining LGE on CMR. Most studies, n equals 6, describe significant LGE as 6 standard deviations, SD, above normal. With this technique, an LGE extent of 10% of LV mass had the best threshold for predicting SCD risk with a sensitivity of 0.73 and specificity of 0.67. Overall incidence of SCD was 10% in patients with LGE greater than 10% and 2.4% in those with LGE less than 10%. Conclusions. In a meta-analysis of CMR studies in HCM patients, LGE was a robust predictor of SCD, irrespective of technique used to assess LGE. However, it is unlikely to be the standalone predictor for SCD risk and is best considered as an additional risk stratifier in patients at intermediate risk based on clinical characteristics. Next, we will be discussing articles from journals of the American College of Cardiology. Sacubitril/valsartan-related hypotension in patients with heart failure and preserved or mildly reduced ejection fraction. Background. Hypotension is a potential adverse effect of sacubitril/valsartan, but there are limited data regarding the predictors and implications of treatment-related hypotension in heart failure, HF, with mildly reduced and preserved ejection fraction. Objectives. We investigated predictors of treatment-associated hypotension, clinical outcomes after hypotension, and the relationship between left ventricular ejection fraction, LVEF, and incidence of hypotension in the Paragon-HF, prospective comparison of RNI with ARB global outcomes in HF, with preserved ejection fraction, trial. Methods. Paragon-HF, randomized patients with chronic HF, greater than or equal to 45%, to sacubitril/valsartan or valsartan. Following randomization, hypotension was defined as investigator-reported hypotension with a systolic blood pressure less than 100 mm Hg. Predictors of hypotension were assessed using multivariable Cox models. Associations between hypotension and clinical outcomes were evaluated in time-updated Cox models. The relationship among treatment, LEF, and incident rates of hypotension and clinical outcomes was estimated using Poisson regression models. Results. Of 4,796 patients in Paragon-HF, 637, 13%, experienced hypotension, more frequently in the sacubitril/valsartan arm, p less than 0.001. Following documented hypotension, patients had higher risk of cardiovascular death and total HF hospitalizations. Adjusted RR, 1.63, 95% CI, 1.27 to 2.09, p less than 0.001. And all-cause death, adjusted HR, 1.62, 95% CI, 1.28 to 2.05, p less than 0.001. LEF modified the association between sacubitril/valsartan and risk of hypotension. P-interaction equals 0.019, such that patients with LEF greater than or equal to 60% experienced substantially higher treatment-related risks of hypotension. Conclusions. In Paragon-HF, higher LEF was associated with an increased risk of hypotension in patients treated with sacubitril/valsartan compared with valsartan. Because these subjects are also less likely to derive clinical benefit from sacubitril/valsartan, our data reinforce that the benefit/risk ratio favors the use of sacubitril/valsartan in patients with LEF below normal, but not at higher LEF. Efficacy and safety of LCZ 696, compared to valsartan, on morbidity and mortality in heart failure patients, with preserved ejection fraction. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Association between a history of breast cancer and decreased thyroid cancer-specific mortality. Context. The clinical relevance of the well-known association between thyroid cancer, TC, and breast cancer, BC, remains to be further defined. Objective. This work aimed to investigate the effect of history of BC on the prognosis of TC. Methods. This was a comparative cohort study of tumor behaviors and TC-specific mortality in 5,598 patients with papillary thyroid cancer, PTC, and 604 patients with follicular thyroid cancer, FTC, all with a history of BC, TC-BC patients, and their propensity score, matched TC patients without a history of BC, TC-NOBKey patients, in surveillance, epidemiology, and end results, SEER, 18. The main outcome measure was TC-specific mortality. Results. Lower TC distant metastasis rates of 2.4% versus 3.0% in PTC, and 6.1% versus 9.1% in FTC, and TC-specific mortality rates of 1.3% versus 2.6% in PTC, and 5.8% versus 8.4% in FTC, were found in TC-BC patients versus matched to NOBKey patients, all p less than 0.05. Comparing TC-BC patients with matched T-NOBKey patients, hazard ratios, HRs, for mortality, were 0.472, 95% CI, 0.370 to 0.601 in PTC, and 0.656, 95% CI, 0.461 to 0.934 in FTC, all p less than 0.05. Such HRs for mortality in PTC were 0.397, 95% CI, 0.268 to 0.588, p less than 0.001, when TC occurred before BC versus 0.607, 95% CI, 0.445 to 0.827, p equals 0.002, when BC occurred before TC. Conclusion. This study demonstrates a robust protective effect of a history of BC on TC-specific patient survival, which has strong implications for more precise prognostication of TC in such patients. Next, we will be discussing articles from Neurology. Association of coffee consumption and pre-diagnostic caffeine metabolites with incident Parkinson disease in a population-based cohort. Background and objectives. Inverse associations between caffeine intake and Parkinson disease, PD, have been frequently implicated in human studies. However, no studies have quantified biomarkers of caffeine intake years before PD onset and investigated whether and which caffeine metabolites are related to PD. Methods. Associations between self-reported total coffee consumption and future PD risk were examined in the EPIC-4PD study, a prospective population-based cohort, including 6 European countries. Cases with PD were identified through medical records and reviewed by expert neurologists. Hazard ratios, HRs, and 95% Cs for coffee consumption and PD incidence were estimated using Cox proportional hazards models. A case control study nested within the EPIC-4PD was conducted, recruiting cases with incident PD and matching each case with a control by age, sex, study center, and fasting status at blood collection. Caffeine metabolites were quantified by high-resolution mass spectrometry in baseline collected plasma samples. Using conditional logistic regression models, odds ratios, ORs, and 95% Cs were estimated for caffeine metabolites and PD risk. Results. In the EPIC-4PD cohort, comprising 184,024 individuals, the multivariable adjusted HR, comparing the highest coffee intake with non-consumers, was 0.63, 95% CI 0.46 to 0.88, p equals 0.006. In the nested case control study, which included 351 cases with incident PD and 351 matched controls, pre-diagnostic caffeine and its primary metabolites, paraxanthine and theophylline, were inversely associated with PD risk. The ORs were 0.80, 95% CI 0.67 to 0.95, p equals 0.009, 0.82, 95% CI 0.69 to 0.96, p equals 0.015, and 0.78, 95% CI 0.65 to 0.93, P equals 0.005, respectively. Adjusting for smoking and alcohol consumption did not substantially change these results. Discussion. This study demonstrates that the neuroprotection of coffee on PD is attributed to caffeine and its metabolites by detailed quantification of plasma caffeine and its metabolites years before diagnosis. Next, we will be discussing articles from CHEST. Symptoms and impaired quality of life after COVID-19 hospitalization. Effective therapeutic heparin in non-ICU patients in the Accelerating COVID-19 Therapeutic Interventions and Vaccines for Acute trial. Background. Therapeutic dose heparin decreased days, requiring organ support in non-critically ill patients hospitalized for COVID-19, but its impact on persistent symptoms or quality of life, QOL, is unclear. Research question. In the Accelerating COVID-19 Therapeutic Interventions and Vaccines for Acute, Active 4A trial was randomization of patients hospitalized for COVID-19 illness to therapeutic dose versus prophylactic heparin associated with fewer symptoms and better call at 90 days. Study design and methods. This was an open-label, randomized controlled trial at 34 hospitals in the United States and Spain. A total of 727 non-critically ill patients hospitalized for COVID-19 from September 2020 to June 2021 were randomized to therapeutic dose versus prophylactic heparin. Only patients with 90-day data on symptoms and call were analyzed. Ascertained symptoms and call by the EQ5D5 leaders at 90-day follow-up in a pre-planned analysis for the Active 4A trial. Individual domains assessed by the EQ5D5 leaders included mobility, self-care, usual activities, pain/discomfort, and anxiety/depression. Univariate and multivariate analyses were performed. Results. Among 571 patients, 288, 50.4%, reported at least one symptom. Among 410 patients, 148, 36.1%, reported moderate to severe impairment in one or more domains of the EQ5D5 leaders. The presence of 90-day symptoms was associated with moderate severe impairment in the EQ5D5 leaders domains of mobility, adjusted or AOR 2.37, 95% CI 1.22 to 4.59, usual activities, AOR 3.66, 95% CI 1.75 to 7.65, pain, AOR 2.43, 95% CI 1.43 to 4.12, and anxiety, AOR 4.32, 95% CI 2.06 to 9.02. Compared with patients reporting no symptoms, there were no differences in symptoms or in the overall EQ5D5 leaders index score between treatment groups. Therapeutic dose heparin was associated with less moderate severe impairment in all physical functioning domains, mobility, self-care, usual activities, but was independently significant only in the self-care domain, AOR 0.32, 95% CI 0.11 to 0.96. Interpretation. In a randomized controlled trial of hospitalized non-critically ill patients with COVID-19, therapeutic dose heparin was associated with less severe impairment in the self-care domain of EQ5D5 leaders. However, this type of impairment was uncommon, affecting 23 individuals. Use and outcomes of peripheral vasopressors in early sepsis-induced hypotension across Michigan hospitals. Background. Vasopressors traditionally are administered via central access, but newer data suggest that peripheral administration may be safe and may avoid delays and complications associated with central line placement. Research question. How commonly are vasopressors initiated through peripheral 4 lines in routine practice? Is vasopressor initiation route associated with in-hospital mortality? Study design and methods. This retrospective cohort study included adults hospitalized with sepsis, November 2020, September 2022. At 29 hospitals in the Michigan Hospital Medicine Safety Consortium, a collaborative quality initiative sponsored by Blue Cross Blue Shield of Michigan, we assessed route of early vasopressor initiation, factors and outcomes associated with peripheral initiation, and timing of central line placement. Results: 594 patients received vasopressors within 6 hours of hospital arrival and were included in this study. Peripheral vasopressor initiation was common, 594, 67.3%. Patients with peripheral versus central initiation were similar. BMI was the only patient factor associated independently with initiation route, adjusted OR, AOR. Of peripheral initiation, per 1 kg/m2 increase, 0.98, 95% CI, 0.97 to 1.00, p equals 0.015. The specific hospital showed a large impact on initiation route, median O, 2.19, 95% CI, 1.31 to 3.07. Compared with central initiation, peripheral initiation was faster, median, 2.5 hours, versus 2.7 hours from hospital arrival. P equals 0.002, but was associated with less initial norepinephrine use, 84.3% versus 96.8%, P equals 0.001. We found no independent association between initiation route and in-hospital mortality, 32.3% versus 42.2%, AOR, 0.66, 95% CI, 0.39 to 1.12. No tissue injury from peripheral vasopressors was documented. Of patients with peripheral initiation, 135 of 400 patients, 33.8%, never received a central line. Interpretation: peripheral vasopressor initiation was common across Michigan hospitals and had practical benefits, including expedited vasopressor administration and avoidance of central line placement in 1/3 of patients. However, the findings of wide practice variation that was not explained by patient case mix and lower use of first-line norepinephrine with peripheral administration suggest that additional standardization may be needed. Zinpentraxin alpha for idiopathic pulmonary fibrosis, the randomized Phase 3 STARSCAPE trial. Rationale: a Phase 2 trial reported clinical benefit over 28 weeks in patients with idiopathic pulmonary fibrosis, IPF, who received zinpentraxin alpha. Objectives: to investigate the efficacy and safety of zinpentraxin alpha in patients with IPF in a Phase 3 trial. Methods: this 52-week Phase 3, double-blind, placebo-controlled, pivotal trial was conducted at 275 sites in 29 countries. Patients with IPF were randomized 1:1 to intravenous placebo or zinpentraxin alpha, 10 mg/kg, every 4 weeks. The primary endpoint was absolute change from baseline to week 52 in FVC. Secondary endpoints included absolute change from baseline to week 52 in % predicted FVC and 6-minute walk distance. Safety was monitored via adverse events. Post-hoc analysis of the Phase 2 and Phase 3 data explored changes in FVC and their impact on the efficacy results. Measurements and main results: of 664 randomized patients, 333 were assigned to placebo and 331 to zinpentraxin alpha. 4 of the 664 randomized patients were never administered study drug. The trial was terminated early after a pre-specified futility analysis that demonstrated no treatment benefit of zinpentraxin alpha over placebo. In the final analysis, absolute change from baseline to week 52 in FVC was similar between placebo and zinpentraxin alpha, -220, 14.89 metamel, and -235.72 metamels, p equals 0.5420. There were no apparent treatment effects on secondary endpoints. Overall, 72.3% and 74.6% of patients receiving placebo and zinpentraxin alpha, respectively, experienced one or more adverse events. Post-hoc analysis revealed that extreme FVC decline in 2 placebo-treated patients resulted in the clinical benefit of zinpentraxin alpha, reported by Phase 2. Conclusions: zinpentraxin alpha treatment did not benefit patients with IPF over placebo. Learnings from this program may help improve decision-making around trials in IPF. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Associations of angiopoietin-2 and vascular endothelial growth factor, A concentrations with clinical endpoints. Background. Angiopoietin-2 regulates endothelial function, partially mediated by vascular endothelial growth factor A, VEGF-A, and may play a role in diabetic kidney disease, DKD. We assessed the association of angiopoietin-2 and VEGF-A with cardiorenal outcomes and investigated the effect of canagliflozin on angiopoietin-2 and VEGF-A concentrations. Methods. 2,565 study participants with DKD and available plasma samples treated with canagliflozin or placebo in the canagliflozin and kidney events in diabetes with established nephropathy clinical evaluation, credence, trial, were included. Angiopoietin-2 and VEGF-A concentrations were measured at baseline, year 1, and year 3. The primary composite endpoint of the trial was a composite of kidney failure, doubling of the serum creatinine level, and kidney or cardiovascular death. Results. Patients with the highest baseline quartile of angiopoietin-2, but not VEGF-A, concentration had the highest risk clinical profile. Treatment with canagliflozin significantly lowered concentrations of angiopoietin-2, adjusted geometric mean ratio, 0.94, 95% confidence interval, 0.92 to 0.95, p less than 0.001, but not VEGF-A. In multivariable adjusted modeling, each 50% increment in log baseline angiopoietin-2 concentrations was associated with a higher risk of primary composite outcome. Hazard ratio, 1.27, 95% confidence interval, 1.13 to 1.43. Angiopoietin-2 change at year 1, compared with baseline explained 10% of the effect of canagliflozin on the primary composite outcome. VEGF concentrations were not associated with outcomes, alone or in combination with angiopoietin-2. Conclusions. Higher angiopoietin-2 levels were associated with cardiorenal risk among individuals with DKD independent of VEGF-A. Canagliflozin lowered angiopoietin-2 concentrations. The association of intra-abdominal adhesions with peritoneal dialysis catheter related complications. Background. This study investigated the association of intra-abdominal adhesions with the risk of peritoneal dialysis, PD, catheter complications. Methods. Individuals undergoing laparoscopic PD catheter insertion were prospectively enrolled from 8 centers in Canada and the United States. Patients were grouped based on the presence of adhesions observed during catheter insertion. The primary outcome was the composite of PD never starting, termination of PD, or the need for an invasive procedure caused by flow restriction or abdominal pain. Results. 758 individuals were enrolled, of whom 201, 27%, had adhesions during laparoscopic PD catheter insertion. The risk of the primary outcome occurred in 35, 17%, in the adhesion group compared with 58, 10%, in the no adhesion group, adjusted HR, 1.64, 95% confidence interval, CI, 1.05 to 2.55, within 6 months of insertion. Lower abdominal or pelvic adhesions had an adjusted HR of 1.80, 95% CI, 1.09 to 2.98, compared with the no adhesion group. Invasive procedures were required in 26, 13%, and 47, 8%, of the adhesion and no adhesion groups, respectively. Unadjusted HR, 1.60, 95% CI, 1.04 to 2.47, within 6 months of insertion. The adjusted odds ratio for adhesions for women was 1.65, 95% CI, 1.12 to 2.41, for body mass index per 5 kg/m2, was 1.16, 95% CI, 1.003 to 1.34, and for prior abdominal surgery, was 8.34, 95% CI, 5.5 to 12.34. Common abnormalities found during invasive procedures included PD catheter tip migration, occlusion of the lumen with fibrin, omental wrapping, adherence to the bowel, and the development of new adhesions. Conclusions. People with intra-abdominal adhesions undergoing PD catheter insertion were at higher risk for abdominal pain or flow restriction preventing PD from starting, PD termination, or requiring an invasive procedure. However, most patients, with or without adhesions, did not experience complications, and most complications did not lead to the termination of PD therapy. Next, we will be discussing articles is from Kidney International Reports. Early rituximab as an add-on therapy in children with the initial episode of nephrotic syndrome. Introduction. The approximately 70% 12-month relapse in children experiencing the initial episode of steroid-sensitive nephrotic syndrome, SSNS, is a significant concern, with over 50% developing frequent relapses or steroid-dependent nephrotic syndrome, FRNS/SDNS. There is a lack of strategies to reduce relapse after the onset. Whether early administration of rituximab, which effectively reduces relapses in FRNS/SDNS, may be a solution, has not been evaluated. Methods. A prospective, multi-center, open-label, single-arm trial was conducted in China, with a 12-month follow-up. Children aged 1 to 18 years with the first episode of nephrotic syndrome, NS, were screened for eligibility. Proteinuria was evaluated daily using dipsticks. A dose of 375 mg/m2 of rituximab was intravenously infused within 1 week after achieving corticosteroid-induced remission. The main outcome was 12-month relapse-free survival. Results. Out of the initially 66 children screened, 44 were enrolled and received rituximab, with all but one participant completing the 12-month follow-up. The median age at diagnosis was 4.3 years. Interquartile range, IQR, 3.4 to 5.9, and 77% of the participants were male. In the rituximab group, the 12-month relapse-free survival was significantly higher compared to historical controls, 32 of 43, 74.4%, versus 10 of 33, 30.3%, p less than 0.001, hazard ratio, HR, 3.76, 95% confidence interval, CI, 1.80 to 7.81. This is. Post-hoc analysis revealed a higher 24-month relapse-free survival and a lower incidence of FRNS/SDNS at the 12-month follow-up. Treatment with rituximab was well tolerated. Conclusion. Our findings support that early administration of rituximab may be associated with a higher 12-month relapse-free survival and a reduced incidence of FRNS/SDNS in children experiencing the initial episode of SSNS. Aversion to a high salt taste is disturbed in patients with CKD. Introduction. A reduced salt intake is a vital lifestyle modification in the management of hypertension. Initiatives aimed at decreasing the intake of salt are based on the preference by humans for a salt taste. Salt intake behavior appears to be affected by the balance between attraction to a low salt taste and aversion to a high salt taste. However, aversion to a high salt taste has not yet been quantitatively investigated in both healthy individuals and patients with chronic kidney disease, CKD. Methods. Assessments of gustatory and aversion thresholds for salt, bitter, sour, and sweet tastes were performed using a stimulant-impregnated test strip in healthy subjects and patients with CKD. Results. In a pilot taste test of 125 healthy subjects, the number of participants with an aversive reaction increased at higher salt concentrations. The threshold for normal taste perception was arbitrarily defined as 10% NaCl, with 47.2% of healthy subjects displaying an aversive reaction. In taste tests performed by 70 patients with CKD, 10% were unable to recognize a salt taste, even at the highest concentration, 20% NaCl, suggesting a significant impairment in taste perception in patients with CKD. Only 15.7% of patients with CKD exhibited a normal aversion to NaCl, whereas 78.6% showed the complete loss of aversion to salt. Conclusion. The present results confirmed the anticipated aversive response to a high salt taste in humans, and demonstrated its impairment in patients with CKD, implying that patients with CKD have reduced resistance to a high salt intake.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.